This is the biomechanical principles. If you can't do the supination, you cannot produce the abduction. This is very, very clear to all of you. So first our step will be supination, then abduction. So whatever is mature children, we find out this is the plantar ligament, so we cut that ligament. So what we do, this is done under local anesthesia. Just feel the calcaneus, take the 15 number blade and rotate by 90 degree. So what happens, the plantar ligament, which is very, very notorious. It is more notorious than the tendon Achilles. So what will happen, you can see that as soon as we have done the plantar fasciotomy, so we have done the serial cast, so most of the deformities were corrected. Gradually we are getting the abduction over here. Now when we have done the abduction, how much degree of abduction we will shall do? Then we do the plantar. This is mandatory. You will achieve the 60 to 70 degree of the abduction, because when you have done the tendon Achilles tenotomy, you cannot correct the abduction. So before doing the tendon Achilles tenotomy, it should be perfectly 60 to 70 degree of the abduction. Now the question arises, how you shall know that there is a 60 to 70 degree? You leave the foot, after plaster removal, you will find that it will come. So the basic principle is, when you apply the plaster, in the plaster when you apply, then you see how this question is very much ignored, because we are not able to understand, because when you do the plasters, we are trying to see, because as soon as we remove the plaster, foot comes again neutral. So we are not able to understand. Then we have find out, one has to do the plaster, in that one have to do the photographs, and you should see how much is the angle. So 60 to 70 degree of abduction is must. When you have achieved that, now the question arises, which is, this is a total tenotomy, partial tenotomy, or the subtotal tenotomy. So basically this is a subtotal tenotomy, because if you see here, this is tendon Achilles. It is in the paratendon. So you cut the tendon anterior, anteromedial and anterolateral. Posterolateral and posterior and posteromedial tendon is shaped. So what you have, when you cut the paratendon, it is stretchable, and in that sleeve the tendon regenerated. Now the question arises, where to do the tenotomy? We have find out, if the child is up to 2 year age, we do tenotomy 1 finger width. 1 finger width is equal to 2 centimeter of the, so 1 finger width above the tendon Achilles. As soon as the age grows, so half centimeter, means 1 centimeter above that, proximal. For example, it is a 3 years boy, so we do 1.5 finger. If it is a 4-year boy, we do 2 finger width. If it is a 5 finger, so we do 2.5 finger width. That is the basic principles. You can see that final photograph after the plantar fasciotomy and the tendon Achilles tenotomy. So again you take the 4 photographs. You see from the top, you see from the side, they sit on that, you see from the plantar surface, and you see some of the back. This is the DiMaglio classification is good. Pirani, we were never able to succeed that. So by doing the assessment, you take the 4 photographs, that will show you. When you try to have the equinus, how much equinus you have corrected. So what happened, that you tell the patient like this, when he raises his heel, that is the true angle, otherwise you can't detect it. This is another boy, 5-year-old with neglected clubfoot. So it has a very severe deformity, many plasters has been done. So in the same manner, we have done the plantar fasciotomy and the serial plaster cuts, and after that tendon Achilles tenotomy. So tenotomy and CL plaster cast. You can see that you will get the perfect plantigrade foot. Now what happens, sometimes the adduction deformity is not corrected. We find out. So we apply any Jess fixator. I think Jess is very good, or Elizarab, because we are not much acquainted with the Jess. So when the deformity is remnant, very well you can apply the Jess fixator and correct that deformity. Now, when we were doing that, we were not knowing that it will be so useful. So we have this technique in the 6-year-old child treated, because I tell you, it's very difficult to, it's a biomechanically very strong, the either Joshi or Elizarab. So for 6 years, you can very well apply this technique. Now the problem arises. These children, they they want to walk. So what we do? We apply the normal gypsonoplaster, and after that 1 layer of the synthetic articast. So because you can't disturb them to walk, so we apply the articast there, so they can walk on that plaster. Now we are talking of the neglected clubfoot more than 5 years. More than 5 or 6 years, we recommended correction of the Elizarov external fixator based on Ponseti principle. We applied the Ponseti principles in the Elizarov external fixator. I was in Agra last year during my election campaign. So I find out there was recurrence of the deformity, as the surgeon asked me what to do. What happens when we do the any posteromedial soft tissue surgery, or I say like this, you draw a line from here, medial malleus to here, and draw a line from here like 30-degree angle there. If you operate in this area, this is a disaster. Lot of fibrosis takes place, because when you abduct the foot, so what happens, there is a lot of fibrosis takes place. So there is a recurrence of the deformity. So one should not operate at all. Our aim is we never operate. I say open surgery is obsolete in the clubfoot. Up till now, all over the world, the calcaneus is fixed with wires during Elizarov correction of clubfoot, violating the Ponseti principles, leading to inadequate correction. Most orthopedists agree that the treatment of the clubfoot deformity should be non-operative, because surgery in the clubfoot is invariably followed by the deep scarring. The abundant scar tissue forms after surgery leads to retracting fibrosis, which further leads to the recurrence of the deformity. Thus, it is advisable to do the minimal surgery. Elizarov extensive fixator can be used in older children or those with very stiff feet, because the fixator is versatile and flexible in application. During the construction of the frame, we have applied the principles of Ponseti in Elizarov fixator. What is the technique? Frame application. Same principle. First apart, correction of the pronation, then metatarsal adductors and heel varus and equinus. So very simple technique. Only 7 wires, 2 wires over here and 2 wires here. This wire will be at the junction of the lower third and middle third of the tibia. These wires at the junction of the upper third and middle third of the tibia. You put 2 wires, one olive wire over the talus, base of the head of the talus, 2 wires first at the first and second metatarsal, and another 4th, 5th and 3rd metatarsal. We have done the cadaveric stage in fresh cadaver. We have tried out where to put the, because this question was asked to many of us, where to put the olive wire. It is the head of the talus at the base of the, because this is a broad area. If you go down, there is a neck of the talus, that is the weak point. So one olive wire over here, you see the second metatarsal, this is first, this wire, where the, at the base of the head of metatarsal, 5th, 4th, 3rd metatarsals. And after that, what we do? I think the Jess is done. What we do, we apply the, here 2 rings, full ring we do. because we have to rotate it here. So what we do, first we give the 3 to 4 millimeter of the distraction so that the ligaments become supple like anything. They become supple, you can move in. It is done manually because when you do the rotation, it will add the abduction as well as supination. So after that, what we do, we have done that, we remove this thread rods, put this thread rod in another holes and rotate it by 10 degree. And before that, we do the plantar fasciotomy. So we do this till we achieve the orientation of the forefoot and the midfoot in the same line. Now when we have corrected the supination, we change our configuration, we do like this and distract here in air so that we can reach over the, in these cases not able to achieve the 70 degree, we have the 30 to 40 degree of the abduction. And when we have achieved the distraction, this is the Cadbury model. So we have shown how we do the correction. One thing I want to tell you, we never fix the Joshi external fixator, they fix the Balkanias. I don't know how it works. But what happens, we have studied that this was the clubfoot here. So as soon as you are fixing this, this will be converted from the virus to valgus heel. In the last correction done in the last after achievement of adequate abduction, frame configuration is changed. Then we do the percutaneous tendoachilles tenotomy and lengthening or VY-plasty. So we remove the full ring, we put the two wires over here and equinus is corrected like bone. Distraction at the rate of 1 millimeter at tendoachilles, or we can do the VY-plasty. So young girl, 17-year-old, 2 surgeries were performed, it failed. So in the same manner, we have applied the same principle over here. First we have done the corrected the rotation of the supination, pronation. Then we have achieved the equinus. We apply the full rings, there is no problem the walking. They have a special sandals like thick, chappal like thing. This was a 90 degree of the equinus. We applied the frame, post-operative X-ray, and you can see the beautifully the whole deformities has been fully corrected. Another girl, you can see the posteromedial surgery was performed, flap rotation was done, we have corrected this deformity. Another girl who was having 2 surgeries, lot of complications took place, even the contracture took place here, the deformities were fully corrected. Now we are doing this technique in the neurogenic foot. That was a case of malingocele. Very big ulcer was there. So you can see that a lot of ulcerations was there. He was walking. People told him for amputation. So we have applied these principles and the deformities were fully corrected. But the only point we find out in the neurogenic foot, there are very chances of the recurrence. So we apply this propellant probe with the pad over here. They walk with this for a long time. We have written a book in which we have described this. This book is being contributed into Baltimore course every year. This book was presented to the Ponseti. He has written a good commentation to us. So the period of study was 2000 to 2012. 0 to 2 year Ponseti caused 845 cases, 0 to 6 year 121 cases, and more than 6 year 43 cases. Conclusion: Ponseti corrected cause is now the standard treatment of a clubfoot from 0 to 2 years. For clubfoot in 2 to 6 year we recommend MICC. For neglected clubfoot more than 6 year, we recommend Elizarov based on Ponseti principles. Wires should pass through talus, not calcaneus. In our series of clubfoot, probably the largest in India, we recommend that open surgery is almost obsolete in clubfoot. Thank you very much.
Thank you, Dr. Agrawal. Is there any speaker other than these two? Dr. Sampath, Dr. Manish Khanna, and Dr. Valimdar Rana.
Any
So,
question if you want to
any
ask?
questions from Dr. Agrawal?
How many wires required for the panels? Only one wire or two wires?
Actually, we put only one wire, that is olive wire. Because initially we have put the two wires in the adult cases, more mature cases. Then we find out that with the two wires, because when we are correcting the deformity, talus also moves. So with the two wires, talus was fixed there. So only we use the olive wire. Second thing, when we are putting the wires, sometimes the wire moves that. So we have to change time to time. I think, I tell you, in the ledger things, is because the multi-directional movements takes place. So basically when you have done 5 to 6, 7 days, then you loosen the things and leave where this is. There is no hinge system that works, as I tell you. So according to tension, according to that, you change the shapes. There is no fixed hinge system, I tell you.
How much time takes?
How much times? What age?
Suppose it is 5 years.
5 years. 5 years, I think, first of all, we do the correction of that takes hardly about 10 days to 12 weeks, 2 weeks. Then equinus correction. I think 4 weeks sufficient for in the 5 years. Usually, but 5 years is better. You do the plantar fasciotomy first, do the plaster, then and not what deformity is left, then you should do. Other you can do that directly, the Elizarov technique. So very well given the whole technique in the book, Ponseti book, which we have written.
So in neglected cases, you have shown good results in 18 to 19 years of age where you have tried Elizaro. In skeletally mature patients, neglected cases, the bones are definitely deformed. How do you explain that they get back to their correct shape?
It's a very good question. We were also worried that how these bones has been corrected. So when we have removed that, we have done the X-rays and CT discussion. What we found, and the second thing, we were very much worried that they will develop the arthritis and it will be very painful. So what we have found, because during the fragments increase vascularity, the bones become very supple. So 50% of the bones shape has been changed, and 50% have been done by the soft tissue correction. By that, because when we are doing that, we find out due to increased vascularity, and other that the bones become supple. For example, if you get the infection, the bones become osteoporous. In the same way, the bones become osteoporous, and they got changed shape itself. So by that we have tried this up to the age of 25 years. There is no problem.
Thank you, Dr.
We
Gawal.
recommend that no open surgery is not needed now in this case.
So is there any brace needed later?
Yeah. Initially, we were not using the brace. After removal of the frame, we have applied the 6 weeks plaster with polypropylene. So they used to walk, and for 2 to 3 years, some bases with the polypropylene we have made. Initially, they walk polypropylene with the pads, 6 months like that, and the night apply. So 3 years we need the braces. Otherwise, the recurrence chances is very, very much. Thank you very much.
Now we'll come to the end of the session. Thank you.
Good morning and welcome you all. The session. Our first speaker, Dr. Pavan Pradhan. He will be speaking on management of complex proximal tibial fracture. Dr. Pradhan.
respected chairperson. I am here to present on complex tibial plateau fractures. There is probably some miscommunication. That's why I have come prepared with this topic. As we all deal with these fractures very commonly in our practice, but they are still challenge. People have tried various modalities, and but we have not been able to land up on the final modalities till yet. As we all know, these fractures are a result of high energy trauma. However, their classification, that is Scheidegger's classification, which we use commonly, is based on only on AP X-rays. It classifies the fractures from type 1 to type 6 as per the severity of injury. However, it underestimates the amount of bone injury, and it doesn't consider the lateral X-rays, and it overlooks the amount of soft tissue injury, which is very important while planning the management of these fractures. These fractures are result of axial loading forces, varus valgus loadings, and rotational impaction forces. All these forces act in combination to produce various combinations. The standard tools in our hand is radiograph. The patient should be extensively X-rayed by AP and lateral X-rays. 40-degree external and internal oblique views give good idea about the comminution. The caudal tilt plateau gives information regarding the tibial slope. The CT scan is very important, and stress views are very important to be taken to tell about the health of the collateral ligaments, which have important bearing onto the results. The careful assessment of the X-rays is important. Fracture geometry should be kept in mind while planning the treatment. The avulsion of lateral collateral ligament and the calcifications of the medial collateral ligament should be noticed while planning the treatment. CT scan, as I told you, is a very important tool. It tells about the articular step off, amount of impaction, and the plain X-rays, which often reveal a benign fracture can turn out to be a grave fracture on CT scan. So it is very important medico-legally as well. Other radiological tool is MRI. It tells about the health of the meniscus, cruciate, and collateral ligament injuries, which are very commonly associated with these fractures, and tells about the soft tissue envelope. MRI angio may be used in cases of suspected vascular compromise. The soft tissue is maybe as grave as like this. We should always be alert. Swollen knees should be observed, and one should wait before the swelling subsides. Bruises and small lacerations must be suspected to have communication with the joint. And meniscal injury, as I say, it is very common, can be seen up to 50% of cases, and cruciate collateral ligament injuries can be seen as commonly as in 30% cases. And more so, these ligamentous injuries are more common in minimally displaced fractures, type 1, type 2, and type 3 fractures, which appear quite benign in X-rays, are commonly associated with collateral ligament injuries. The compartment syndrome is also a frequent occurrence, may be seen in 10 to 20% of cases, and one should be ready to deal with this exigency. Now the treatment. As I told you, these are difficult fractures. One should always take care of the soft tissue, and only after soft tissue has healed properly, then we should intervene into the treatment. Conservative treatment is a limited option. This can only be used in low energy trauma and the fractures which are stable in varus and valgus stress. However, non-ambulatory patients can also be treated by conservative methods, by above knee POP cast and cast bracings. The surgical intervention is the gold standard of treatment, and however, surgical intervention should be done only after the soft tissue has healed properly. Any articular depression of more than 5 millimeters or any instability due to depression more than 10 degree in less than 20 degree of flexion is the criteria for surgical intervention. And all the open fractures, fractures with compartment syndrome, and floating knee are the absolute indications for the surgery. As I told you, planning of these fractures is very important, and we may have to use spanning fixators quite often because the skin condition does not permit early intervention. Wherever possible, we should use the indirect reduction techniques, because by this we can minimize the soft tissue trauma, and once the indirect reduction has been achieved and the skin condition permits, we can intervene by putting plates and screws and bone graft wherever is required and do the definitive fixation. These are the few cases where I have intervened by putting 2 plates. This is first case. This is another case, surgical type 6. I have fixed on one side by extensive approach, on another side we have used routinely MIPO techniques and putting a decent bridge of skin between the 2 incisions. These are the final X-rays. This is the final outcome of the patient. This is another case, surgical type 6. Again we have fixed. There is posterior middle component. We have used L buttress plate on one side and 3.5 mm reconstruction plate from posterior middle side. And this is another case which has got also the femoral component. We have waited for some time and then this fixation has been done. We have put both the plates on the tibial side by MIPO technique. And 1 month post-op, you can see the wounds have healed. If we put the plates with minimal tissue damage, we can have good results. This is another case. This is floating knee injury where a spanning fixator was applied and then the fixation was done. LCP on the femoral aspect, and on tibia we have used the buttress plates to fix these fractures. This is the X-ray, which is quite normal looking injury. As I told you, the CT scan reveals there is avulsion of tibial spine and anterior cruciate ligament. The fixation has been done and the tibial spine has been fixed by a 4 mm screw, and these are the 3 months post-op X-rays. This is a recent case which has got the posterior middle component. Again, this fixation has been done. We have tried to use screws and plates of lesser size. We have preferred not to use 6.5 mm cancellous screws. We prefer to use less bulkier implants, and this is the fixation, 3rd post-op, and this is the 5th post-op day. I have just taken these photographs 2 days back. The patient is doing physiotherapy on the 5th post-op day. So my carry home message is that complex tibial plateau fractures requires meticulous planning. One should always take care of soft tissues. Indirect reduction is a better technique, but wherever it is required, direct reduction should be done. Bicondylar plating is gold standard. However, we should use less bulkier implants, and at least on one side we should do fixations by MIPO technique. On one side we can be invasive and can perform direct reductions. Soft tissue is major concern, so soft tissue should be handled carefully.
Thank you, Dr. Pawan Pradhan. We'll actually have the discussion and the questions at the end of all the 3 lectures. So it's basically a common topic, so people can discuss it later on. Thank you. Can we have the next lecture, please? The next speaker is Dr. Lazar Chandy. He'll be speaking on complex tibial fractures, which I'm surprised 2 lectures are similar, but that's how the organizers have kept it.
Anyway, there's bound to be overlap and there's bound to be repetition, but it's a revision once again. So greetings from Kerala and my hospital in Cochin. Thank you to the organizers of having me here. The topic is high energy complex tibial plateau fractures, and the objectives of this talk would be to define complex tibial plateau fractures, the indications for open reduction and internal fixation, the importance of CT scan and 3D CT, general principles of management, to be aware of a distinct group of posterior vertical shear fractures which are also very complex. The type 5 and 6 Schatzker and the AO type C fractures are called complex tibial plateau fractures because their management remains clinically challenging. injury is associated with significant damage to two or more of the following compartments. That is the soft tissue envelope of the knee, the ligamentous stabilizers, or the bony structures of the distal femur and proximal tibia. If two of these are involved, then Schern and Lobenhofer says this is the complex knee trauma. These are one of the most difficult fractures to treat, and however you treat it, you get about 50% satisfactory result either with closed or operative methods. The failures of treatment are usually due to residual pain, stiffness, instability, deformity, recurrent effusions and giving way. The methods of management involves making decisions: operative versus non-operative, direct versus indirect fracture reduction, percutaneous fixation versus ORIF, and internal versus external fixation. There are only three absolute indications for immediate surgery. They are open fractures, an acute compartmental syndrome, or a fracture-associated vascular injury. Or in all other cases, you have to go by the state of the patient, the associated injuries, state of the limb and soft tissue envelope. Now, if it is decided to postpone the surgery, put the limb in traction or bridge the joint with an external fixator like this. The treatment of the soft tissue and the skeletal injury must occur concurrently. The associated injuries are neurological and vascular injury, compartment syndrome, deep vein thrombosis, contusion or crush injury to the soft tissues or the crush injury syndrome, open wounds. And the patterns of injury, Schern and Lobenhofer says that there are 67 meniscal injury percentage of meniscal injuries in plateau fractures, and if a dislocation is involved, then there is 96% cruciate ligament injuries, 85% medial collateral ligament injury, and the peroneal nerve injury is twice as common. The mechanism of injury, as my previous speaker said, is varus, valgus, axial compression or combined, but the direction of force indicates the type of fracture, and the magnitude of force leads to the complexity like displacement and fragmentation, and the quality of bone, the osteoporosis. The treatment of soft tissues, early surgical incision is harmful to the integrity of the soft tissue envelope, and placement of surgical incision is to be considered carefully, and you have to be prepared for rotational flap or free tissue transfer. This is an example of a closed complex tibial fracture and an open fracture. Investigations, again, plain radiograph, CT scan, 3D construct, MRI angiography. And in the radiograph, the traction radiographs is very important, especially if you don't have CT facilities. This is the 2D CT axial and coronal system and the 3D CT. It helps in better planning for surgery. It is a good tool for intra-articular fractures, and it gives an idea about the situation of the depression, the orientation of the articular fragments. So if you have a 3D CT and you can go through, and it gives a much better idea about how these fragments are situated in the fracture anatomy. The classification I am not going to detail, it is the AO and the Schatzker classification, but now these are based on appearance on the AP radiographs, and these are in the coronal plane fractures are visible only on the lateral or X-rays or the CT scans, and if displaced fractures in the coronal plane are not addressed, they may lead to inappropriate fixation techniques. This was first brought to light by Timothy Bhattacharya in 2005. The goals of treatment are atraumatic anatomical reduction, image intensifier control, elevation of depressed fragments en masse, reduce and temporarily stabilize, bone graft defects in the metaphysis, definitive stable fixation, and early mobilization. The quality of reduction correlates with the clinical outcome, and therefore anatomical fracture reduction without intra-articular step-off is an important goal in the treatment of tibial plateau fractures. Now, lateral plateau fracture, more than 3 mm step-off, more than 5 mm widening, and lateral tilt of more than 5 degrees, you have to do open reduction internal fixation. The treatment options are conservative, open reduction internal fixation, and external fixation. And Schern and Lobenhofer said that we prefer treatment on open reduction and internal fixation in all displaced and unstable tibial plateau fractures. Now, this is the plan. Usually there is a large posteromedial fragment That has to be reduced first and stabilized with a posteromedial plate, buttress plate, and then you can come to the lateral side and fix it. If there is a depression, it has to be elevated and bone grafted. You can also do it by hybrid fixation or by ring fixators. The position is supine. The C-arm and radiolucent table is a must. Radiolucent knee blocks are a must. And if you have to bone graft large defects, consider preparation of the iliac crest also. In small defects, you may use bone substitutes. The anterolateral approach is the approach to the lateral side. You can have a submeniscal approach, and the posteromedial approach on the medial side between the pes antherinus and the gastrocnemius muscle. Exploit the fracture gap to elevate the depression and then use large blocks of bone substitutes to support it. And this is how the C-arm guided elevation is done. And your reduction aids are your assistant, acetabular forceps, ball spikes, femoral distractor, external fixator, and plates. These are the different instruments that are used, and the plates on the lateral upper tibial, proximal tibial plate. This is an example of a type 6 short scur, elevation, bone grafting to fill the gravity, reduction and temporary fixation with graft, and interfragmentary compression, and then buttress plate with the lateral plate. That's the final picture at 3 months, and this is the function. He has got almost full range of function and an almost normal gait. Now this is a 39-year-old male, road traffic accident, type 5 short scur, compartmental syndrome, a fasciotomy done on the second day, and low tibial traction and open reduction internal fixation at 2 weeks. Just see the complexity of the fracture, which is evidenced by the 3D CT. These are the postoperative X-rays. We had used 3 plates, one because the tibial tuberosity was avulsed off. And these are the post-op X-rays. If you are very adventurous, you can do the post-op CT to find out if your reduction is good. This is a 26-year-old male, type 5 short scur. Oh. Can you help me with this? This is a type 5 short scur injury. See, we have used 3 acetabular forceps for reduction, and then we have used the elevated the bone, grafted it, temporarily fixed it, and then interfragmentary decompression has been used, and a posteromedial buttress plate has been used. We could get away with one this thing. She has already had a compartment syndrome for which fasciotomy has been done, and this is the outcome at 2 months. This is the 3C open grade 5 short scur injury. Again, interfragmentary compression with the external fixation has been done. The gastrocnemius flap has been elevated, bone grafted. The flap has been applied, skin grafted, and this is the function at 1 year. Now, you have to be careful about secondary loss of fracture reduction. It can be due to absorption of elevated fragments, pressure from femoral condyle on a comminuted articular surface, or failure of internal fixation device. So be careful that you prevent loss of reduction, and it is much easier than correcting it later on. The approaches, the traditional approach I've already said. The more recent are the posteromedial, the posterolateral with fibular osteotomy or without fibular osteotomy, and the posterior approach. Now this posterior shearing tibial plateau fracture has been underappreciated previously. It's an uncommon injury, and the AP shows little displacement. Accurate analysis of lateral view and CT clarifies the fracture pattern. Direct posterior approach and plating of the posterior shear fractures result in restoration and maintenance of alignment. This is a 34-year-old male road traffic accident. This is a preoperative X-rays. This is the 3D CT. You can see again the sections as well as the 3D, and you can appreciate the fracture displacement, the depression of the fracture. And it is very evident in when you see these 3D, you get a mental picture of how to reduce these fractures. This is the posteromedial approach. This is a prone position. The medial head of the gastrocnemius is elevated, depressed lateral condyle and elevation of this thing, and then applying 2 plates, one medially and one laterally. And this is the post-op film. You can see that there's an interfragmentary compression with 1 screw and 2 plates applied on the posterior aspect of the tibia. And this is again a post-op 3D CT where it shows that our reduction has been elevated and it is in satisfactory position. Again, the posterolateral fracture, at least 7% of all tibial plateau fractures lie in the region of the posterolateral corner. And fractures in this region usually cannot be adequately treated by using a lateral or an anterolateral approach. So this is the approach without fibular osteotomy, and you can plate apply the plate on the lateral side. Now, if none of these things are possible, then the primary use of TKR may be considered as an alternative treatment for elderly patients with intra-articular fractures of the tibia not extending past the metaphyseal area. The indicators for poor results: varus malalignment of greater than 5 degrees, valgus tilt of greater than 10 degrees, articular displacement of greater than 4 millimeters, and condylar widening of greater than 10 millimeters. In conclusion, these fractures are a challenge to the skill and experience of any orthopedic surgeon. You have to have a thorough preoperative planning. The soft tissue envelope has to be cared for. The timing of the surgery and the placement of the incision has to be accurate, and delicate soft tissue handling. The availability of an array of different instrumentation and implant options should be there. Atraumatic anatomical reduction, elevation of the plateau en masse, bone grafting of the defect in the metaphysis, stable internal fixation, and physiotherapy for early mobilization. Thank you for your patient hearing.
Thank you, Dr. Chandi. Thank you very much. Our next speaker is Dr. Monappa Naik from Manipal. He will be speaking on extra-articular fracture of proximal tibia. Dr. Naik.
Respected Chairperson and my friends, greetings from department and my university, Manipal University from Karnataka. Extra-articular proximal tibia fractures. The job is simple. It is not involve the articular surface, as the caption says, and non-isthmic region. That means within 4 centimeter distally from the tibial tubercle or 6 centimeter from the joint surface. So these fractures are different from other fractures involving the tibial shaft. They are good for the surgeon because the job is easy. The articular surface is intact. There is no need of reconstructing it, and no issues of articular surface, step off, all those things. It's bad in the form of displacement, the short length of the proximal fragment and the deforming forces, and there is no standardized protocol for this fracture management. So they are bad in that sense. And the aim of managing these fractures are to align and connect the block to the shaft. The alignment requirement is the outcome should be less than 5 degrees of varus valgus angulation, and we should achieve less than 10 degrees of flexion extension deformities, and less than 1 centimeter should be the shortening. Then only the alignment must be useful. So much of already discussed about the soft tissue management of the proximal fragment, proximal fracture of the tibia, because these fractures are very close to the vessel very close to this bone there. So vascular injury, compartment syndrome, soft tissue problems are well known with these fractures. Why these fractures fail? These fractures fail because the proximal segment is so small, there is no control over the small segment. Probably the intact fellow bone, the fibula, is blamed most of the time, and the tendinous attachments of the strong muscle forces pulling this fragment into different directions, and that causes difficulty in maintaining these fractures in reduced position. When you see the literature, way back in 1979, Sarmiento, 68 patients of this type are close treatment done purely extra-articular proximal tibia fractures, and there are a lot of complications. Whereas angulation more than 5 degrees, almost in 14 patients of 23 intact fibula. So that means the fibula was blamed. The fibula acts as a lateral buttress. On starting weight bearing, it drifts into varus. So that's why the close treatment has failed frequently. Then surgery has been told the gold standard nowadays. Yes. Is it nail with screws or plate with screws? So the options are there. Malunion of nailing is a common complications of malunion. That is when you nail these fractures. 58%, as I say, 58% have been reported in 1995. This is a small series of 16 cases series by Friedman. Later, Lang et al. 32 fractures have been nailed, proximal extra-articular, and see the complication rates. More than 5 degrees of angulation, 84%. It's a big number. So, is it ideal to nail these fractures? Or we should do some tips and tricks, corrections of the problems? How the nailing fails? The nailing fails because of anterior apex malalignment. So the proximal fragment goes into extension, and that causes anterior apex angulation. Valgus deformity is very common in the proximal fracture nailing, and the nail can push the distal fragment posteriorly as well as distally. The fracture may get distracted. Why? That whole thing is blamed because of the anatomy. The proximal metaphyseal diaphyseal region of the proximal tibia is voluminous. It's very wide. So the nail is not taking any purchase over the cortex to reduce or keep the reduction in situ. Deforming forces. When you keep the knee in flexion for nailing, the tendinous portion pulls the proximal fragment into this deformity. So to avoid that, we can keep the knee joint in near extension. So nail these fractures in extension or around 30 to 40 degrees of flexion. The second most varus valgus problem is because of the entry point. When you do an entry point in these fractures for nailing, it should be very high up. So probably in the non-weight bearing portion of the articular surface, more anterior in the plateau, and it should be more on the lateral side. So it should be on the medial border of the lateral tibial spine. When you see in the image, it should overlap the lateral tibial spine, and it should go as high as possible, and it should be parallel to the anterior cortex. When you pass the guide wire, it should be nearer and parallel to the anterior cortex, and probably we need a arthrotomy incision. Bigger incision, medial, commonly used, and lateral we can do, and nowadays the modified suprapatellar incisions are in. The Herzog bend is most of the time is blamed. When the Herzog bend is too far off, then this Herzog bend goes to the distal fragment and it pushes it posteriorly and probably distracts the fracture. The number of locking screws in the proximal fragment is very important when you lock these fractures. 2 screws must be put. So fragment should be long enough to accommodate 2 locking screws, and the crisscross oblique locking screws are very useful to control the loss of reduction at a later date. So combination of these transverse as well as oblique locking screws are must. So 2 to 4 screws are needed most of the time. So you can use sometimes to maintain the reduction which you have achieved, and then you pass the reamers and the nail. Anterior plate you can use temporarily, or you can leave that plate if it's too small. And polar screws, as we know, very useful. Distractor can be used, and percutaneous clamps you can use to keep the reduction intact. So with all these tips and tricks, my senior colleagues have done a study of 45 consecutive cases of proximal tibial fractures which have been nailed and published in Injury 2006. And all these tricks, the fractures complications has been reduced to 15%. 7 cases had malreduction. So nailing, there are a lot of technical difficulties. Surgeon should be very experienced, and a lot of implant specifications. Nail should be having a proximal Herzog and lot of number of screws in the proximal end. So to avoid this, is the plating is an answer? Probably yes. A minimally invasive which is biological and pre-contoured anatomical plates, angle stable plates nowadays, we can use it as a minimally invasive. So I think this is very useful, because in this we can do the fixation with the knee in extension. There is no need of flexing the knee. So the deforming forces is taken care, minimally invasive, need not to go into the joint, and angle stable. So we can put more number of screws here, 3 to 5 screws. We can get the indirect reduction by properly using the screws, and you can get the alignment well, and it is minimally invasive. So MIPO with LCP can get good results like this. And consecutive cases of 49 cases have been done in our institute, and we have published the report in injury in 2013. And when we see the complications, the earlier report, the nailing has done well than the plating in our hand. So one study report is there combining both the comparative study of these two. This is a retrospective study, and there is no distinct advantage of nail over the plate or plate over the nail. So evidence-based, Cochrane-based study of Mohit Bhandari says there is no definitive implant which is more advantageous or having benefit over the other one. There is no conclusive report to say which implant does well in these cases. So nailing is successful when the proximal fragment is more than 5 to 6 centimeter long and can put more than 2 screws, locking screws, and surgeon is experienced in nailing. Locking plate, very useful when the fracture is very high up, and osteoporotic fractures, probably if the surgeon is very aware of the locking plate concept. So to balance it, probably a surgeon's decision, surgeon's experience to choose the implant and the technique. So by that we can bring a better outcome. Thank you for all.
The session is now open to questions from the audience, please. Could we have the mic, please? Please give the mic.
The first study which was done, there was only need 2 situations, polar screws. Otherwise, when you take care of other things, polar screws may not be needed at all. Polar screws do useful when you put it on the concave side of the deformity which is developing. It is dangerous. It should not be very close to the fractures. It may shatter the fracture again. That's the problem. Technical problem.
My question to Dr. Pradhan. Sir, where will you manage for soft tissue injury, intra-articular soft tissue injury for meniscus, cruciates and collateral ligaments after stabilization of fracture fixation?
Sir, if collateral ligament injuries are there, they can be managed simultaneously, or screws can be put. For them, I have done in one such case where we have to put collateral ligament injuries, but if we suspect meniscal injuries and cruciate ligament injuries, they should be managed later on once the fracture fixation has been taken place by orthoscopic surgeons.
Other questions? Okay, I would like to ask a few questions. This question is common to Dr. Pawan Pradhan and Dr. Chandy. Sir, both of you mentioned that the indications for among the indications for operative fixation are depression of more than 5 mm. Sir, but to the best of my knowledge, I think it is slightly different if the depression is on the medial side or the lateral side.
3 mm and 5 mm, yes.
Yeah, because as a standard teaching, 5 mm depression should not be accepted. 5 mm or 4 mm depression on the medial side is unacceptable, because the depression should be equal to the or not more than the depth of the cartilage, and the depth of the cartilage on the medial side is less, so it is less resistant to depression. So as a standard statement of a depression of less than 5 mm being acceptable is only true for type 1, 2 and 3. But when it comes to 4, 5 and 6, it should be, for the benefit of the younger surgeons, it should be, I think, elaborated on. Another question, sir, I want from Dr. Chandy. Sir, when you, in your protocol of fixation, you mentioned that you would, for a bicondylar fracture, you would proceed with the medial side first. Is that true, sir? Sir, maybe I got it wrong, but I think you said that you will proceed for the medial side first, decrease the medial side first, fix it, and then proceed on to the lateral side. Is that what you said, sir?
Not definitive fixation.
Yeah, sir.
The medial side, because if you have a large posteromedial fragment, it's always easier and better to stabilize the posteromedial fragment first because it's large. And then once you stabilize it with temporary fixation with K wires, then you get the lateral side. Most probably you'll have to elevate the lateral side, and therefore you elevate the lateral side, you do your bone grafting, and then you can fix the medial side and the lateral side.
Absolutely, sir.
Yeah.
So one more statement in your presentation was that posterior shearing fractures are relatively uncommon fractures. Sir, in the January issue of the American Academy, they've come out with a white paper on proximal tibial fractures, bicondylar fractures, and they've said that in the analysis of bicondylar fractures, they did 3D reconstructions and found the incidence of involvement of the posteromedial fragment and that to shearing segment to be as high as 50%, and the portion of the articular surface involved in the posteromedial condyle to be as high as 40%. So now the concepts are that it is relatively a common injury. It's not uncommon anymore.
Yeah, this is exactly why I brought this segment into the complex fractures, because they are not actually in the original description as complex fractures. These are relatively new to this thing, and the actual shear fractures are the vertical shear fractures that you're talking about. The posteromedial fragment, which was there earlier also, that was not considered in these vertical shear fractures, that is the posterior and the lateral and the medial posterior shear fractures. So that is the one which has been now coronal fractures. That is the one which has now been more and more into the limelight, along with the bicondylar fractures. So the posteromedial fragment fractures were there before also, but they were not strictly the shear coronal fractures. So the other entity which is now more and more coming into the limelight is compared to the other bicondylar fractures rare, and it is more difficult to stabilize also. Unless you are aware of it, you can't, sometimes you have to go real posterior rather than posteromedial. Many of them can be addressed posteromedially, but some of them you have to go posterior, especially if you want to fix the more lateral ones. You can reach them through the posterior incision, or you can go posterolateral.
So one last question to Dr. Pawan Pradhan. We still have time, there could be more questions. Sir, in your X-rays, in your X-rays of dual plates,
Yes.
there were a few X-rays in which you had done an anterolateral plate and an anteromedial plate.
Yes.
That is to say, both your lateral and the medial plate were anterior plates.
Sometimes, yes.
Did you ever find problem of soft tissue? And what prompted you to go in for two? Because the normal teaching is if you're going with an anterolateral, you go with a posteromedial or a medial. Because if you have less, the bridge in between, chances of vascular compromise would rise.
This I have kept in mind, that there should be a decent bridge of 7 centimeters between the two incisions, and on one side I have used MIPO techniques. I have not done extensive surgeries, and we have slided the plate by minimally invasive approach. This is the standard practice that I told in my lecture, that I have used on one side I have done open reductions, on another side we have only used MIPO, sliding the plate.
Which side were you preferring the MIPO on?
On anterolateral side, I have commonly used the open technique. On the medial side, I have slided the plates.
Yeah, because I mean, in my very novice hands, trying to achieve a medial alignment is far more difficult with a MIPO technique on the medial side.
That depends. I have told I would try to reduce the fractures indirectly, and once the fracture has been reduced, and which is more comminuted portion, I have intervened by open method. On another side, I have gone with the MIPO technique, whichever is easier.
Yeah, one more question, please.
Even there, you can use the MIPO technique both on the lateral side as well as the medial
yes,
side.
In one case, I have used on both sides MIPO technique.
Because you don't require a large incision on the lateral side.
Yes,
All
sir.
you require is to elevate the
Yeah, but if you have a posterior conal involvement, then MIPO never works.
No. There you will have to go by a posterior approach. Yeah.
No, MIPO doesn't mean the articular fragments have to be anatomically fixed. The MIPO means only the alignment for the diaphysis. So you open up the articular surface and fix it, and then the MIPO actually means for the diaphysis, for the alignment. So you can do both incisions, MIPO, and sometimes I'm sure that many of us would have seen on the medial side, not posteromedially, on the medial side there is instability after you fix the lateral side, and in such cases I would go with them and slide a plate in and put just 2 or 3 screws, more than enough.
Yes.
Sir, you have seen that you are plating in tibial plateau fracture. You have done a posteromedial incision, curve incision. Same incision you are doing both plate. The plate was not lateral plate, but anterolateral plate.
Yeah.
So dual plate in single incision or dual incision?
No, 2 incisions. The lateral plate is with a anterolateral incision. The posterior plate which I have put is through a posteromedial incision. Yeah. So we can go still posterior by elevating the
But the
gastrocnemius.
plate is seeing that just anterolateral.
It's
Just anterior.
anterolateral. In one I have shown
There
3
is no
plates.
problem of necrosis and anything.
No, you just do MIPO. That's the best. Yeah.
So dual incision.
Dual
You are
incision.
doing one incision,
Yeah.
but you are doing with 2 incisions.
In one I showed 3 plates, and we have no problem with soft tissue because the tibial tuberosity was avulsed. It was reduced, closed, and then MIPO technique you put another plate on.
Sir, would you advocate fixing tibial plateau if they're avulsed in all cases? Would you advocate fixation of the tibial plateau?
Tuberosity.
Yeah, tuberosity.
Yes.
Yeah.
You can include that in the construct so that the cruciate ligaments are repaired along with the bone.
So thank you very much, Nadia and Doshan. Thank you so much.
Thank you, sir.